Choosing Wisely Canada is a national campaign aimed at reducing unnecessary tests and treatments in healthcare. In this video, we present one of the top 5 dermatology recommendations for physicians and patients, which are set by the Canadian Dermatology Association and Choosing Wisely Canada. Don't prescribe systemic anti-fungal medication for nail infection without mycological confirmation of dermatophyte infection. We'll start with a case. You are a third-year medical student on your family medicine rotation seeing Erin, a 57-year-old woman with history of type 2 diabetes, dyslipidemia, and remote lower leg cellulitis 2 years ago. She presents today with a few months' history of yellow-white discoloration on her left great toe. She complains of nail brittleness and thickening. She takes metformin and lovastatin, and social history and family history are unremarkable. On examination, you see onychomycosis at the distal corner of her left great toe with yellowing of the nail and subungual hyperkeratosis. You suspect a diagnosis of onychomycosis. What is the next step of management? Do you start anti-fungal therapy? Onychomycosis is the most common nail disorder, accounting for 1/2 of all nail diseases with a worldwide prevalence of 5.5%. It is a fungal infection of the nail bed, matrix, or plate, and can be caused by dermatophytes, non-dermatophyte molds, or yeasts. Risk factors include trauma, immunosuppression, history of diabetes or psoriasis, previous history of onychomycosis, hyperhidrosis, and family history. Beyond cosmetic concerns, onychomycosis can sometimes restrict mobility, lead to cellulitis in older adults, worsen conditions such as diabetic foot ulcers, and spread to other areas of the body. Onychomycosis presents as yellow to white spots or streaks on the nail, subungual hyperkeratosis, thickening of the nail, and distal onycholysis. There are different types of onychomycosis. While distal lateral subungual onychomycosis is the most common, proximal subungual and superficial onychomycosis often presents in immunosuppressed patients. Given the diverse presentation, there are various conditions that can actually mimic onychomycosis. Other infectious conditions to consider are paronychia, subungual and periungual verruca. Inflammatory causes can be attributed to nail psoriasis or lichen planus. Iatrogenic causes include chronic trauma leading to traumatic onycholysis. Benign neoplasms include onychomatrachoma and subungual exostosis. Lastly, malignant neoplasms are subungual squamous cell carcinoma or subungual malignant melanoma. Instead of memorizing each item on the list, it is more important to recognize that onychomycosis can have various mimics, therefore appropriate diagnostic testing is crucial. If you suspect onychomycosis clinically, diagnostic confirmation is indicated. This is because empiric antifungal therapy can lead to inappropriate and unnecessary treatment and increased risk and harm to patients. We will explore each diagnostic method and its relative advantages and disadvantages. Factors such as cost, test availability, and clinician skill may influence which diagnostic test you proceed with. There are 4 main ways to confirm a fungal infection depending on what tools you have available. First is the potassium hydroxide or KOH prep. This requires a microscope and potassium hydroxide drops. Second is the PAS staining or histopathology, which require formalin specimen bottles to be sent to the lab. Third is fungal culture, which require collection of nail substrates only. And lastly, PCR. Potassium hydroxide preparations are a quick and efficient test that can be performed in the office in a matter of minutes in diagnosis onychomycosis. Some disadvantages include low sensitivity and low specificity. As well, you are unable to identify the exact organism and viability, and the test depends on clinician expertise. The steps to obtain a sample for KOH preparation is as followed. 1. Clip the nail as far back as possible. 2. Use a curette or the back of a Q-tip to collect subungual debris at the site of involvement, and then scrape the sample onto a glass slide. 3. Use a cover slip to cover the scrapings. 4. Apply 2 drops of 20% KOH stain to the edge of the cover slip. 5. Wait a few minutes until KOH dissolves the larger keratinocyte material. Heating with a flame for a few seconds may make it easier and faster to find the fungal elements. And lastly, use a light microscope to determine the presence of fungal elements like hyphae, pseudohyphae, or yeast cells. If you don't have the tools, you can simply collect the subungual debris in a fungal kit and then send it to the lab for microscopy and fungal culture. One major advantage of fungal culture is the ability to identify the organism and its viability. The test is higher in specificity, but still has lower sensitivity. Therefore, almost 1/3 of cultures may return false negative. Fungal culture results are often not available for several weeks. For histopathology with periodic acid Schiff PAS stain, the nail clipping and attached subungual debris must be placed in 10% formalin before examination. It has high sensitivity for onychomycosis, but cannot differentiate fungal species or assess viability. Lastly, polymerase chain reaction, or PCR, can be useful in rapidly identifying the organism by detecting fungal DNA. PCR is highly sensitive and specific, thus may be used as a diagnostic tool for onychomycosis. PCR can detect non-viable fungal DNA. Disadvantages of PCR include low availability and higher cost. The overarching goal of therapy is to eliminate the fungal organism causing the infection and restore the nail. Mycological confirmation of dermatophyte infection should be done prior to initiating treatment because 50% of cases of clinically suspected onychomycosis do not have dermatophyte or other fungal etiology. Once the diagnosis of onychomycosis is confirmed, systemic antifungals, which have proven to be cost-effective with relatively high curative rates, can be started. Terbinafine is indicated for mild to severe onychomycosis and commonly used to treat dermatophyte infection, but has some coverage against non-dermatophyte molds and candida. Side effects include headache, GI symptoms, and rash. Itraconazole is also commonly used with broader coverage compared to terbinafine. Side effects include headache, upper respiratory tract infection, GI symptoms, elevated triglycerides, and transaminases. Another well-studied regimen with lower risk of toxicity is fluconazole once weekly for 6 months. The rate of clinical cure is about 45 to 60% with several months of treatment. It is not appropriate to start systemic antifungals when the diagnosis is unclear. Although major adverse effects are not common, they can have significant impact or harm on patients. Be cautious in prescribing oral antifungals in patients with heart disease, liver disease, HIV, or those on multiple medications. For terbinafine, the medications that cause drug-to-drug interactions can include beta blockers, antiarrhythmics, tricyclic antidepressants, SSRIs, and warfarin. Itraconazole can interact with statins, phenytoin, carbamazepine, and antivirals, and it should not be used in patients with congestive heart failure. Baseline liver function should be assessed before treatment with use of these medications. Topical antifungals like efinaconazole and amorolfine are not as common as systemic antifungals as they have poor penetration of the nail plate and have a longer course of treatment. Topical treatments should be reserved for cases with minimal nail involvement. Topical antifungal agents are applied to the nail once daily for 48 weeks. It is a treatment of choice for children as no systemic therapies have been FDA approved in this population. Additionally, children have thinner nail plates and potentially faster nail growth, which makes them more appropriate to respond to topical treatment. Going back to the case, a KOH stain confirms Erin's diagnosis of onychomycosis. She would benefit from systemic antifungal therapy since she has diabetes, therefore would be at an increased risk of cellulitis if not treated. Her past history of lower leg cellulitis makes treatment indications even stronger. Since Erin is on metformin and lovastatin, she should be prescribed terbinafine over itraconazole to decrease the risk of drug-to-drug interactions. From this video, we hope you understand the CWC's recommendation of don't prescribe systemic antifungal medication for nail infection without mycological confirmation of dermatophyte infection. The take-home messages of this video are 50% of suspected onychomycosis is not caused by fungal infections. Consider other infectious, inflammatory, trauma, and neoplastic causes. Use KOH preparations, fungal culture, histopathology, or PCR, if available, to confirm the fungal infection prior to treatment with systemic antifungal medications. Consider patient's current medical history and medication list when selecting the appropriate therapy. Contraindications for systemic antifungal treatment include patients with significant liver, renal, or heart disease.